Okay.
Hi, everyone. Glad you're tuning in. I'm Dr. Stephen Masley, and we've got a special program for you today. And I have a guest I'm really thrilled to get to speak with and for you to listen to. I have Dr. Dale Bredesen, neurologist, professor at UCLA, the founder of the Buck Research Institute, and the author of The End of Alzheimer's, a New York Times bestselling book. And now he's got out a new book, and we're going to talk about some of the really amazing tips that come out of this new book, the End of Alzheimer's program. So I've read this and I think it's fabulous. Certainly anyone who's concerned about cognitive decline or memory loss, this should be on your absolute essential reading list. So Dr. Bredesen, very nice. Thank you for joining us today.
Thanks so much, Stephen. Really appreciate it.
Now, I think as many of our viewers know, we were scheduled to do this about 2 weeks ago, but fires in California at the last moment forced us to reschedule. So thank you so much for rescheduling and making sure this happened. Now, your community's okay, I hope. I mean, tell me just real briefly, how are things going there?
A lot of people lost their homes, unfortunately. And of course, power was shut down numerous times. And that was one of the issues a few weeks ago, unfortunately. And of course, the big long-term issue has been the air quality, where, of course, air pollution has been associated with cognitive decline in the future. And the air quality was quite bad for a while. So we do have an increased risk. Fortunately, everything came back to pristine and everything came back to clean. And so things are pretty much back to normal, fortunately. So thanks so much for asking. And I know you guys are dealing with things like hurricanes, tornadoes, or tropical depressions and things like that. I hope everything is good in Florida.
We are. This is an unprecedented time with COVID, with planetary climate warming, and rising rates of Alzheimer's and memory loss. We know that over just the next decade, they're predicted that Alzheimer's, if we don't do anything, that Alzheimer's rates are projected to double. So I think my first question, just to get some background for our listeners about you and, as a neurologist, how did you get started on this current track? In terms of how did your Alzheimer's work begin? And I'm really curious, when did you have that aha moment when you realized that, wow, I've got a program that could actually help prevent and reverse Alzheimer's? So can you tell me a little bit about that?
Yeah, it's a great point. So I had been interested in the brain from when I read a book and when I was a freshman in college. I read a book called The Machinery of the Brain by Dean Wooldridge. Got very interested in the workings of the human brain. And then from there, I got interested in, so what goes wrong? Why is this such an incredibly common problem? And of course, then I got interested in the fact that there really isn't any good treatment for neurodegenerative diseases. As you know, people say everyone knows a cancer survivor, no one knows an Alzheimer's survivor. This has been the area of greatest biomedical therapeutic failure. And so we spent 30 years studying, why do neurons die? Why do you lose these things? Why is it so incredibly common? And in 2011, we were actually developing drugs that would change the fundamental nature of whether the signaling to specific synapses was to keep the synapse or to pull back. And you have both going on, all the time. And so as we were going through there, we developed a drug that we were going to take into trial, which actually went into trial in Australia. But we realized, well, wait a minute, there are many other signals that all do this. So I realized this is a little bit like, trying to change a huge country or a company. You've got all these constituents, and it's like you've got to make sure that everything works together. So we thought, okay, let's do a trial in which we address all these different things. Well, they would not allow us to do that trial in 2011. They wanted it to be a single variable, and we said, but that's not the way this disease works. So the big aha moment was actually in 2012, after we had been turned down to do the trial. Actually, a patient was sent to me who had cognitive decline, whose mother had died with Alzheimer's. And I told her, look, we got turned down for our trial, but you can go back to your doctor, and here's the whole set of things. Here's how this network works that we've been studying for all these years. You need to address all the different things that I talked about in the new book. And she called back after 3 months and said, I can't believe it. I'm back at work full time. My memory's better than it's been in 20 years. And I thought, okay, we're on the right track with what we were doing in the test tube.
And during this, you've realized there's more than one cause of Alzheimer's. I mean, there's many things. There's dozens of factors that contribute to it.
Right.
But over time, you've been able to group this into like 3 different types of Alzheimer's. Could you talk a little bit about the 3 types and why is that important, and how does that impact the therapy plan we offer to people who face cognitive decline?
Yeah, that's a great point, because so many doctors are just trying to say, we don't know what causes this. Let's just treat it the same way for each person. And that really doesn't work. It's just like, people get cancer for different reasons. Of course, some people are going to be related to smoking, and some it's going to be related to genetics, and some it's going to be related to carcinogens, and so forth and so on. As we started to evaluate different people, what we found is that each person has a different set of things that are contributors, and typically multiple contributors. So we actually ultimately found 6 different types. So there's inflammatory, or type 1. There's atrophic, or type 2, where you have reduction of support for all these 500 trillion synapses you have. And then there's type 1.5, which is glycotoxic, where you have a little of both. You have some inflammation due to the glycation, but you also have an atrophic effect because of the insulin resistance. Then there's type 3, which is toxic, and the toxins come in 3 groups. It's either the metals and other inorganics, things like air pollution, or it's organics, things like toluene, benzene, formaldehyde, glyphosate, or it is the biotoxins, things like mycotoxins, things like that. That's type 3. Type 4 is vascular, just reduction in the support for the brain because of low oxygen, low blood flow, things like that. And then type 5 is traumatic. So if you've had head trauma, you are at increased.
Yes, of course.
So those are the 6 different types. And you're absolutely right. You have to look for each person and target the things that are actually driving the decline.
Now, one of the themes behind your interventions, I mean, there's many depending on the type of Alzheimer's you have and what the testing shows. It's a personalized program to deal with it. But one of the general recommendations I think you make for most people has to do with fasting, how long we go at night without eating.
Right.
And could you talk some about that, like clarify the difference between 10, 12, or a 15-hour fast, and how does that physiologically impact the Alzheimer's process?
Yeah, it's a great point. And again, you can look at what's actually driving this process. You can literally follow the molecules into the cells to see what's driving this. And then you can fashion a program for each person that addresses those things, which is what we do. So for the fasting is an important piece because it has, as you know, multiple effects. Number 1, it increases autophagy. So as you go, and we recommend if you're ApoE4 negative, which is about 3/4 of the population, you typically want to go 12 to 14 hours. You can go longer if you want, but a minimum of 12 hours. If you are ApoE4 positive, you're actually better at absorbing fat, and so you can actually go longer, and so therefore 14 to 16 hours. And again, some people like to go even longer, depending on who you are, depending on your BMI. You have to be a little careful. If you're very thin, got to be careful about that fasting, and you may want to supplement at the beginning with exogenous ketones, and that's an important piece. So getting people into ketosis really hadn't been appreciated, I think, as such an important part of dealing with cognitive decline. If you look at a PET scan of someone with cognitive decline, as you well know, Stephen, for years before you develop and actually have a diagnosis of Alzheimer's, you have a reduction in glucose utilization in the temporal region. Yes. And the parietal region. That is the signature of Alzheimer's disease. So you really have an energy gap, and we need to bridge that energy gap immediately. So we recommend for the first few months, just take exogenous ketones. Get that ketone level up between 1 and 4 millimolar beta hydroxybutyrate, or if you're using a breathalyzer like Biosense, then get it up above 7 ACEs on the acetone so that you can actually supply the appropriate energy to your brain. It was huge. And then over time, you can now develop endogenous ketosis. So as you mentioned, what are the things? You get ketosis, you get autophagy, which helps to essentially to clean, to get rid of the various damaged mitochondria, things like that, and basically renew. And then in addition, you have changes in terms of your insulin sensitivity. As you know, you have changes in blood pressure. People who do fasting actually do better overall with their blood pressure. So you really have a resetting. You're changing the molecular biology of your mTOR, your response to nutrients. And so you really do change multiple factors that are all critical for cognitive improvement.
Just to follow up with that, now, the beta amyloid formation that tends to form during the day more when we're in fuel eating stage, we tend to remove more beta amyloid at night when we're in a real fasting stage. Is that beta amyloid removal rate ketone dependent, or is that just associated with fasting itself?
It's a great point. It is associated with fasting, and especially associated with sleep, and especially associated with inflammatory status. So you're right, there are multiple parameters that are critical for the removal. And again, it's not just about, you're not trying to remove the amyloid if you need the amyloid. And this is, again, where everything's been backwards because people have not understood this disease. This is very much like COVID-19. So what's happened with COVID-19? We have an insult, SARS-CoV-2. We're all told, go in and we're going to social distance, and we're going to shelter in place. We're going to stay away from each other. And so what's happened? We've developed a recession in our country as we're trying to protect ourselves. That's exactly what happens in the brain of someone with Alzheimer's. You have an insult, and it can be many different things. It can be P. gingivalis from your mouth. It can be F. nucleatum. It can be herpes simplex, for example, from your lip. It can be metabolic syndrome, leaky gut, chronic sinusitis. There are all these different things that can affect your brain. Your brain responds by protecting itself, by downsizing, just as with COVID-19. And in this case, you're making amyloid, as you indicated, and that amyloid is actually a protectant. It is part of your innate immune system. It is an antimicrobial. It's killing these things that are coming into your brain. But in so doing, it's also downsizing. So unfortunately, as long as you have that ongoing insult, you're going to continue to downsize until you can't dress yourself, you can't speak, et cetera, et cetera. So we need to identify what those things are, what those insults are, so that we can now rebuild.
Well, that's why the drugs for trying to remove beta amyloid didn't help. Right? Because beta amyloid is a marker. It's not the cause for the cognitive decline.
And as you know, last week, huge news. So the first news that came out was that the FDA had enough information to approve aducanumab, which was an antibody which removes amyloid. Then just 2 days later, there was a panel of experts that recommended strongly against approving aducanumab. And so this is a huge issue. Now, is the FDA going to listen to the expert panel, or are they going to be bullied by the drug company? And we'll see what they decide. But this is the issue. I actually think these sorts of drugs are going to be helpful when used in a completely different way. After you remove all the different insults, after you start healing people, now you want to get rid of the amyloid that's been sitting there for years. But if you get rid of it early, you're losing that protection. And we have seen a number of people who started with just that and actually got worse with each of the injections. So again, you have to think about this in what it's actually doing to your brain.
So for those of you who might have come in late, I just want to update you. This is Dr. Dale Bredesen, who's speaking now, author of The End of Alzheimer's and his new book, The End of Alzheimer's Program, professor at UCLA, and neurologist who's really, I think, done something remarkable in giving us hope about preventing and reversing Alzheimer's disease. So again, thank you for being with us here. On the fasting, the most common questions I get actually have to rate with tweaking it. Yes, they'll agree to, okay, we're going to do a 12 to 15 hour fast. Well, here's the details that come up, and I'm just curious your response to these. I know what I've told them, but I want to hear your response. So in the morning, when people are having their tea or coffee, commonly, something I've not taken away from them, but it's what they put in the coffee that is the concern. Certainly sugar would be out. I don't think anybody's who's been following my, blog or Facebook posts, they're totally no surprise. There's no sugar or refined carbs put in here. But some of them are asking me about using half and half or a little heavy cream. 2 tablespoons of half and half has 1.3 grams of carbohydrate.
Yeah.
2 tablespoons of heavy cream would be 0.7 of what? How's that going to impact their fasting and their results if they end up adding that to their coffee? What is your take?
It's a great point. And as you know, there are a couple of guidelines. Number one is that you don't want to have any simple carbohydrates like sugar, as you mentioned. Number two is it's okay to have things that will keep you in ketosis. So that's the ketosis part is critical. So you want to put some MCT oil in there. It's not going to take you out of ketosis. That's fine. Number three, the total calories should not be more than 50. Generally speaking, as you know, you hit 50 calories, now you're really breaking the fast. So as long as you follow those general guidelines, now, dairy has its own issues. For some people, it's quite inflammatory. Yes. Some people are lactose intolerant. So, you also have to look at your own proclivities. But to the extent that that's fine for you, as long as you're not going over 50 calories, you're not doing simple carbs, and you're keeping yourself in ketosis. And by the way, try it. Just measure your ketones, have your coffee, measure your ketones again. And measure them 30 minutes after that. And if you stayed in ketosis, as you should have, then you're good to go.
Okay. Oh, well, that I think that's actually really good advice, and I think that'll help some people out there who were really, that was their biggest concern. They don't want to drink their coffee totally black. So what could they do? Yeah, I mean, and if you're dairy free, I mean, MCT oil is a good option. You just have to put it in a blender to get in there. You can't just stir it in with a spoon. It's going to float on the surface. It won't really work.
Yeah, good point.
All right. How about the part about fasting 3 hours before you go to bed? I know you in your book you talk about 12-3. So how important is that you stop caloric intake 3 hours before going to bed?
Right. So as you pointed out, we call this keto flex 12-3. So it's, ketosis, it's flexitarian, and it's a minimum of 12 hours for fasting, and it's a minimum of 3 hours before you go to bed. And again, it's a good guideline because if you're eating close to bed, you're doing a couple things that really hurt you. You are increasing, of course, you're increasing your insulin. You're now interfering with your melatonin at night, so you're interfering with your sleep. You're increasing your cortisol as well. So, and for those who actually have a little bit of a leaky gut, you're also causing this inflammation. And as long as that inflammation is going on, you are making the A beta to deal with the inflammation. It's really interesting. Professor Fiala at UCLA has measured the ability of our white cells, of our monocytes, to take up the amyloid. And when we have any sort of inflammation going on, they will not take up the amyloid. Literally, your white blood cells will allow the amyloid to stay high because they're saying, hey, you're inflamed. You need this stuff to protect you. Yeah. So you actually have to get someone in a calmed down state for you to now begin to take that up and get rid of it. So all of those reasons, we want to have at least 3 hours before we go to bed. Again, I think everyone finds eating before bed really interferes with your sleep. It really interferes with autophagy and interferes with ketosis. It hurts. And as you know, there's some beautiful work just looking at allowing rodents to eat right up, to eat anytime versus eating. And they literally can have the same diet. If they eat it early in the day, they do much better with their metabolic parameters than if they eat it late in the day. So all of us should be thinking about eating earlier in the day and not in the several hours before.
Especially blood sugar control.
Absolutely.
Now, I've been talking about fasting for a while here because I think it's so important, and people have been having little specific questions on how to fine tune that to make it work for them. But this is anything but a single intervention trial. This is a multi-intervention. So Talk to us about testing and a cognoscopy. This whole concept that you brought up on, we assess your cardiac static with all sorts of testing, but up till now, we haven't really done much to assess for the brain. So can you talk about how can someone find out what kind of testing they should get? Where could they go to get that? And then lastly, what does that kind of testing cost? Just so people are aware of what they're facing.
That's a great point. Yeah. And I think that is the most critical point. So let's take a step back for a moment and look at what has been done until now. Everything and all clinical trials have predetermined a treatment that has nothing to do with what's actually causing the cognitive decline. If you think about it, it makes no sense. And we've gone after this and we've simply said, yeah, we don't know what causes the disease. Let's give this drug. Over 400 clinical trials have failed at a cost of billions of dollars. So what we're saying is, let's change that around completely. Let's now look at each person and look at what are the contributors. And typically we find between 10 and 25 different contributors. There may be some insulin resistance. There may be some toxins on board. There may be some pathogens. There may be chronic sinusitis, on and on. There may be a change in the oral microbiome, on and on. So the idea then is you want to look at each of these, as you said, so you can get a cognoscopy. Just as everyone knows we should get a colonoscopy when we turn 50, anyone who's 45 or older should get a cognoscopy. And that's simple, 3 things, and you can do it directly online. You can go to mycognoscopy.com. You can do this directly online. And so you need to have a set of parameters. You need to know, do I have systemic inflammation? Do I have insulin resistance? What is my HOMA-IR? As you know and you deal with all the time, this is a huge issue. Do I have specific hormones, nutrients, or trophic factors that are too low? All of these things you can deal with. And so, in fact, this should be a very rare problem. And so you mentioned, how do you do it and what does it cost? So if you're just there, so there are 2 different ways to go. If you're just interested in prevention, so you have absolutely no symptoms, you got to be careful because these things do sneak up on us. And some people who think they're coming in for prevention already have problems when we test them. And I should mention the cognoscopy has those 3 pieces, some simple blood tests, online cognitive assessment, and then if you have symptoms, you should also have an MRI with volumetrics. But if you don't have symptoms, you don't need the MRI. So it's pretty simple. And you're looking at all these different parameters, which unfortunately, most practicing doctors are not looking at. And what does it cost? If you're just doing the prevention, then it costs about $300. It's not terribly expensive because you're looking at a smaller set of things for prevention. If you're interested in reversal of cognitive decline, then it's costing about $950 because you're doing more tests. In both cases, we generate a report based on a computer-based algorithm that looks at what are all the things that are placing you at risk or that are likely to be contributing if you already have some degree of decline. And then we want to target those things. And I should say we're just finishing the first clinical trial in history, and I'm really excited to be working with 3 fantastic functional medicine physicians, Dr. Anne Hathaway, Dr. Deborah Gordon, Dr. Kat Toops, who are just doing a fantastic job and targeting the different things. So this is really the future of medicine. This is a precision medicine, personalized protocol that literally identifies the drivers of your cognitive change or the risk factors if you're not symptomatic yet, and then targets those things. And if all of us did this, we really could make Alzheimer's a very rare disease, just as it should be.
Well, just to follow up with that, like mold testing. I mean, that's something that would not normally be offered by a regular allopathic practitioner.
Right.
But it's like blood sugar abnormalities. Yes, I think they know if your blood sugar is high, that's an issue. But my guess is it's probably less than 10% of people that have something more comprehensive that's looking at hormones, key nutrient factors, and toxins like mold or mercury or other things that can have a significant impact on increasing someone's risk for cognitive decline.
That's a good point. And as you know, the standard of care, which over 95% of people are not doing these appropriate things. And what they're doing, as you said, they're not looking at even your HOMA IR, for example, they're not going to be looking at. They're not looking at your mycotoxins. They're not looking at your oral microbiome. They're not looking at whether you have leaky gut. All of these things that are actually critical contributors to cognitive decline are just completely ignored. And so the response is, we don't believe in this stuff, and we know there's nothing you can do about it anyway, so we're just going to give you a drug. And that's why it fails time after time after time. To get the best outcomes, you do have to look at what's driving the decline, and then you have to address it, or what's driving the risk for decline, and then address those things. And again, everybody can do this. We can all essentially guarantee ourselves that we're not going to have cognitive decline in the future. And this has been such a huge issue, as you know, because of the currently living Americans, about 325 million of us or so, there are about 45 million of us will develop Alzheimer's disease if we don't do it. It is now, as Professor Christine Yaffe from UCSF published a couple of years ago, it has become the third leading cause of death in this country after cardiovascular disease and cancer. So it's a huge, huge problem.
And the most expensive disease in America today.
Absolutely. And as you know, the average patient will end up spending $350,000 by the time of death. And of course, a lot of that is going to the nursing home. So let's keep everybody out of the nursing homes. By preventing the problem, we can really drop this. It's a $300 billion per year problem for our country.
So the intervention, though, is not just one faceted. And I like this. I mean, this multifaceted intervention, which includes food, sleep, toxins, hormones, personalized to address the key things.
Right. So
can you emphasize the importance of addressing all those factors? I mean, one of the analogies you'd given me before I really liked was, I think you mentioned a roof. And if I believe you said there were 27 holes. Right. And by patching 6 of them, the roof still leaks. So and so that we do have food and sleep, and maybe give an example of sleep apnea. And I'd always look pretty strictly at like that 90% cutoff, but you're talking about even below 96% if your oxygen levels don't drop below 95 at night, that we can see issues. Could you expand upon that, please?
Yeah, that's a great point. And as you indicated, there are many things. Of course, we'd like to be able to just give one pill and fix everything, but that's not the way the human brain works. There are many different things that can impact your brain, so you have to identify them and you have to do something about them. And there was a paper published a couple of years ago, beautiful study, looking at simply the mean SpO2. So in other words, the average oxygen saturation at night, which now you can measure easily. This quantified self that's so available now, we can all get, whether you do it through an oximeter or an Apple Watch or Oura Rings or Better or all these different things. You can look at your sleep. You can track ketones, sleep. We can now track our glucose. There's all sorts of things that are available to us that weren't available even 5 years ago. It's really fantastic. So if you look at the mean oxygen concentration at night, and then you compare it to the various regions of the brain, you actually see that there's a direct correlation. Let me move on to the screen here. So there's a direct correlation. As your oxygenation goes down, then in fact the size of these various nuclei in your brain go down as well. So you really get brain atrophy as your oxygen is going down at night. So therefore, it really behooves all of us to make sure that our oxygenation is appropriate at night.
But in that, you're talking about optimal oxygenation. I think that's true for a lot of these tests, like even blood sugar or others. If there's an optimal level, there's a cutoff for abnormal. There's an improvement between optimal and what would be normally like below 90% is disease, but you're basically showing that anywhere from 90 to 95 is suboptimal and may be associated with some brain shrinking, if I understood that correctly.
It's a great point. And yes, we've seen this, for example, with homocysteine, where normal is up to 12, but optimal is only up to 7. We see this with B12, where, quote, normal B12 used to go down all the way to 200. In some tests, they've moved it up a little, but optimal is above 500. So you don't want to sit, you don't want to be walking around with a B12 level of 320. It's not optimal for your nervous system. And so same sorts of things with oxygenation, same sorts of things. And we as physicians, of course, have this within normal limits, which only means 2 standard deviations from the mean. It doesn't tell you what's good for your body or your brain. So we want to get people into the optimal level. And of course, the same can be said for all of these things, from vitamin D, testosterone, estradiol, progesterone, thyroid. All of these things, we want to get people in an optimal level because we're talking about keeping you sharp until you're 100. I mean, that's the whole idea.
Absolutely. Yeah, I'm in total favor of that concept. Optimal health till 100 years of age, and eventually we'll have some decline.
Absolutely.
Well, it's really been an honor and a privilege to get to speak with you today, Dr. Bredesen. Thank you very much again for this book, The End of Alzheimer's Program, by Dr. Dale Bredesen. So I encourage everyone who's concerned about cognitive decline, for you or for a loved one, to read this. I think it's really valuable information. Thanks for sharing that. How can people learn more about your program? I mean, what resources are out there available so they can continue to learn from you over time?
Yeah, thanks for asking, Dr. Masley. So yeah, so you can go on drbredesen.com, see all the information that we talked about today. You mentioned the book. You can also, we've published some papers on this. You can also look under mycognoscopy.com. We now also just have come out with a training for practitioners, for physicians, for neuropsychologists, for nurses, for health coaches, all of these things. And you can go on drbredesen.com to look for the training as well, or Apollo Health Co. We're working with Apollo Health, which is a Silicon Valley software company, because we need these algorithms to give people best outcomes. So all those places you can find more information.
Well, any last points you'd like to share or bring up with our guests out there today? Any questions any of our followers want to answer, please put them in there. But what final questions would you pose for us, or you want to share during our last moments together?
I think just to recognize that we are now in the 21st century. A lot of medicine is stuck in the 20th century, unfortunately. Medicine, as you know, has been about tradition and permission. We are slow to change, but in fact, we now have the ability to make sure that all of us can stay sharp to a ripe old age, and we should take advantage of that. So I encourage everyone, please don't wait. Please either get on prevention, or if you begin to have the very even minimal beginning symptoms, please make sure that you get these taken care of as early as possible, because there is now something that can be done, and we really can work together to reduce the global burden of dementia.
Well, and I want to echo that, because I think a lot of people are waiting for something bad to happen. Like they have a heart attack. Yeah. Okay, now they're motivated to take care of your heart.
Yeah.
They get colon cancer. Okay, now they're motivated maybe to make some dietary changes after they get it treated. But with your brain, I mean, your brain is potentially shrinking.
Yeah.
And you may not even know that for the first 10 to 20 years, even though you're losing significant function. So I would implore people to not wait. And the biggest benefit isn't just that you're preventing disease, but you feel so much better. You can, I mean, all of my research and findings them show we can improve our cognitive function. We can be sharper, quicker, and better at work and having fun and just enjoying life to the fullest. So don't wait, take action now. Again, thank you so much for joining us today. I really appreciate it. So thank you everyone for tuning in. Thank you, Dr. Bredesen, for being here.
Thank you, Dr. Masley. Great to talk to you.
Okay, thank you everyone. Goodbye.